Bismillah ar-Rahman ar-Rahim. I am Zeinab Awad, Professor of Pediatrics. I will give you a lecture on rheumatic diseases of childhood. This is part 1 of the lecture and you will find part 2 in a separate video. This lecture will present to you the common manifestations of rheumatic diseases, will help you recognize the specific clinical features of two of the major rheumatic diseases of childhood, namely lupus and dermatomyositis. It will provide you with the important laboratory investigations that will help you diagnose this condition and give you the broad lines of treatment of these diseases. The rheumatic diseases of childhood are called also collagen vascular diseases or autoimmune connective tissue diseases, are characterized by autoimmunity and inflammation that might be localized as in organ-specific autoimmune diseases or generalized in the systemic autoimmune diseases. The hallmark of most of these conditions is chronicity. They take a chronic course, but the course exhibits periods of exacerbations and flare of the disease and periods of quiescence of the disease. Common presentations in these conditions are the presence of joint pains, myositis, rashes, fever, anorexia, loss of weight, etc. The presence of a high ESR, an ESR that reaches up to 100 should make you suspect either a rheumatic disease, tuberculosis, or malignancy. So when you find a very high ESR, think of a rheumatic disease. Also, the presence of autoantibodies raises suspicion of autoimmune diseases. Systemic lupus erythematosus, this is a chronic inflammatory multi-system disease of unknown etiology. There are many theories that are suggested for the etiology of lupus. The disease is characterized by periods of quiescence and exacerbations. What is the meaning of a multi-system disease? It's a disease that has manifestations involving two or more organs or systems. There is production of large amounts of autoantibodies in this condition that circulate in the blood and become deposited in the tissues and lead to tissue inflammation and damage. This autoantibody formation is the result of the loss of the T lymphocyte control on the B lymphocyte activity. Systemic lupus erythematosus has its onset mostly after 5 years of age, and it's rare below that age, but it can be seen as early as the first year of life. It's more common in females, especially after puberty, where the female to male ratio is 8:1. We should suspect SLE in any patient who has a multi-system disease, that is, a disease that has features of two or more organs or systems involvement. And a person is said to have systemic lupus erythematosus if he has 4 of the 11 criteria that are mentioned in the table in the next slide. These 4 manifestations that should be present out of the 11 criteria may be present at the same time simultaneously, or they may present serially during any period of observation. These are the ACR criteria for the diagnosis of SLE. They are modified in 1997. And we have 4 manifestations involving the skin and the mucous membranes: the malar rash, the discoid rash, photosensitivity, and the mucous membrane manifestation is the oral ulcers. The malar rash is fixed erythema. That is erythema that is present day and night in the sun and in the shade. It's fixed erythema, that which is flat or raised, and its presence of the malar areas, the cheeks and the nose, and it spares the nasolabial folds. This is characteristic of the malar rash of lupus. The discoid rash is another form of rash seen in systemic lupus. It's an erythematous rash appearing in the form of patches that has adherent scales on top, and it's folliculated and may leave atrophic scars. Photosensitivity, as the name implies, that is reaction and inflammation of the skin with redness, maybe blistering when the patient goes out in the sun. Oral ulcers, these ulcers are usually painless, and you might also find nasopharyngeal ulcers, either this or that. Then there are inflammations of the serous membranes and the synovial membranes. This table is completed in the next slide. The inflammation of the synovial membrane, which is arthritis, and arthritis here is non-erosive, involving more than two joints with effusion and tenderness. So this is one of the criteria out of the 11 criteria. The other serous membranes, which are the pleura and the pericardium, inflammation of any of these is considered 1 point. Renal disorder, the presence of proteinuria more than 500 mg per 24 hours, or the presence of cellular casts, whether RBCs, granular, or tubular casts. Neurologic disorder is important and is in the table of the American College of Rheumatology for the diagnosis of lupus. And the manifestations are seizures or psychosis, either this or that. And you have to exclude in any of these conditions that these were not the result of drugs or uremia or anything else. The hematologic disorder, which are changes in the blood elements. So we have hemolytic anemia with reticulocytosis, or the patient might have a total leukocytic count less than 4,000, demonstrated on 2 or more occasions. The patient might have lymphopenia less than 1,500 per millimeter cubed on 2 or more occasions again, or there is thrombocytopenia less than 100,000 per millimeter cubed, and we must prove that this is not drug induced. Any of these 4 hematologic disorders or all of them are considered 1 point. So when the patient has hemolytic anemia, lymphopenia, and thrombocytopenia, he is considered or she is considered to have 1 of the 11 manifestations. The immunologic disorder, which is anti-double-stranded DNA, anti-Smith antibody, or anti-phospholipid antibodies. The anti-phospholipid antibodies are either the anticardiolipin, IgG or IgM, or the lupus anticoagulant. Positive anti-nuclear antibody is considered 1 criteria, and it alone takes 1 point because it is very important. And any claims that there is a patient with lupus who has a negative anti-nuclear antibody should be revised. But we have to exclude that this is not the result of drugs such as phenytoin, because there is drug-induced lupus caused by anticonvulsants, anti-arrhythmic drugs, and antibiotics, namely the sulfa drugs. These are photographs of lupus in female adolescents. In the one on the right-hand side, you can see the malar rash sparing the nasolabial folds. In the one on the left, you can see severe reaction and redness of the skin when the patient was exposed to sun. The oral ulcers are seen in the picture on the right side. These ulcers, you have to ask the patient about them, because he might not notice these ulcers, because as we said, they are usually painless. This picture on the left-hand side, the hands of a girl with systemic lupus, and you know why she's a girl? Because she's wearing a ring. These are her hands. You can see the punctate erythema of the palms and over the tips of the finger. This is a characteristic finding in patients, but it's not in the 11 criteria. This is the discoid rash, which are patches or plaques of erythema that has scales on top and might leave atrophic scars as well. Other clinical presentations that should raise suspicion of lupus and are not in the 11 criteria, for example, alopecia, chronic urticaria, and mind you here that some of the patients are diagnosed first as cases of allergy and they are treated with antihistamines and anti-allergic drugs, but they prove by time that they are cases of lupus. And we had a patient, once upon a time we had a patient like that, and we found in her urine analysis proteinuria, so we started to think that this patient is not a simple case of allergy, and the patient proved to have systemic lupus. Patients might also have lymphadenopathy, hepatosplenomegaly, inflammation in the heart, in all layers of the heart, especially the endocardium, and this is called verrucous endocarditis or Liebman-Sachs endocarditis. Inflammation, as we said, in the kidney, the nephritis, might result in frank nephrotic syndrome, and as I've told you in the table, that just the urinary changes are considered one of the 11 criteria, but frank nephrotic syndrome also can occur. Also, autoimmune thyroiditis is among the other clinical presentations. How we are going to investigate a patient with lupus? First, you have to do the immunologic tests that I have mentioned in the table. You have to assess disease activity to see if the patient is passing by an exacerbation or not. A high ESR, consumption of complement 3 or 4, and a high anti-double-stranded DNA titer, all these are indicative of the presence of disease activity. Notice here that I didn't put anti-nuclear antibody because it is present early in the disease, but after the patient starts steroid therapy, it rapidly becomes negative, and so we cannot follow the patient and the activity of the disease with the anti-nuclear antibody. We have to do tests to evaluate the various organs in the body, renal functions, renal biopsy, ECG, CNS investigations, all that. We have also to test for drug side effects, to monitor the drug side effects, especially if the patient is on steroid therapy. You have to monitor the blood sugar, and you have to do ophthalmologic examination to see if the patient developed cataract or bone density, patient has osteopenia, and so on. The general lines of therapy of a patient with lupus, these are important, and they are as important as the immunosuppressive drugs. The patient should take good rest during flares of the disease. The diet of the patient should ensure that he does not go into obesity or hyperlipidemia, because these patients do not walk or do activity because of the pains. And another point, because of the steroid therapy, they develop obesity. And again, because of steroid therapy, you have to supply the patients with potassium, calcium, and vitamin D. The photosensitivity should mandates that the patient should put sunscreens before going out to the sun. The patient should use topical glucocorticoids for the rash, and the patient will need, those patients who are on immunosuppressive therapy should not receive live attenuated vaccines. They can take it after you stop the immunosuppressive therapy. If the patient has mild manifestations like arthritis, you may start by giving a non-steroidal anti-inflammatory drug. You can introduce anti-malarial drugs like hydroxychloroquine if the patient has significant cutaneous manifestations. Oral steroids like prednisolone are given at doses according to the severity of the condition. If the patient has mild disease, you may start by giving half to 1 milligram per kg. If the disease is more severe, you can give the full dose, which is 2 milligram per kg per day. Severe cases also need intravenous methylprednisolone. You may add immunosuppressive drugs like azathioprine or cyclophosphamide. Intravenous immunoglobulins are given in some cases, and these act in two ways. They block the already present autoantibodies, and they inhibit the production of more immunoglobulins. Plasmapheresis may be needed in order to get rid of the circulating immune complexes, and recently the biologic therapy helps in patients with severe conditions in order to decrease the production of autoantibodies, like the anti-B lymphocyte biologics, which is rituximab. It acts against B lymphocytes and reduces the production of immunoglobulins, autoantibodies. With proper management, the 5-year survival is 90%, and infection is an important cause of death in these patients. Systemic lupus erythematosus may occur in the neonatal period. This happens when the mother has active systemic lupus during pregnancy. Her autoantibodies pass through the placenta to the fetus and result in manifestations that are very similar to those occurring in the mother. These antibodies that are transmitted through the placenta are the anti-Rho antibodies, and the manifestations, all the manifestations like the rashes, the cytopenias, hepatitis, etc., resolve usually within few months. But if congenital heart block develops, then this is permanent and may require pacemaker. I will continue this lecture in part 2, and please prepare your questions in the next face-to-face session.